Hello, and welcome to the second episode in the series, where today we'll look at areas for improvement in suicide research, especially when it comes to evaluating and enhancing the theoretical and conceptual frameworks that we use. Today's discussion will address how to advance the state of suicide research and move beyond the main theories that currently dominate the research and highlight important concepts that may be missing or overlooked. So I look forward to a discussion with our guests about ways that we can refine and broaden these perspectives to improve our understanding and interventions related to suicide. I will be one of your moderators. My name is Suzanne Bailey. I'm a social worker and currently the development team lead with the Canadian Forces Road to Mental Readiness program. And I'm excited to have Christine, my co-moderator, introduce herself before we have our guests introduce themselves.
Thank you, Suzanne. So I'm Christine Jeunesse. I'm from Université de Montréal. I'm at the Faculty of Nursing, and I'm also a researcher at Centre d'études sur le trauma in Montreal, so doing research on suicide prevention.
Right, thank you. Johnny, did you want to introduce yourself?
Yes, absolutely a pleasure. So my name is Johnny Morris. I use he, him pronouns. I'm very grateful to be here today on unceded and ancestral Lekwungen speaking territories. I have the honor of serving as the CEO for the Canadian Mental Health Association's BC division here in British Columbia.
All right, thank you. And Sharon, from the other side of the globe, did you want to introduce yourself?
Yes, hello everyone. My name's Sharon Lawn. I'm a professor in public health at Flinders University in Adelaide, which is on Kaurna land in Australia. And I pay my respects to elders past, present and emerging for First Nations wherever they are. I'm a researcher in mental health at Flinders University, but also run a national lived experience mental health advocacy organisation.
All right, thank you. And Jitender, coming from the Centre of Canada this morning.
Hi there. I'm Jitender Serene. I'm professor and head of the Department of Psychiatry, and really looking forward to the conversation today.
So thank you, everyone. For starting, we need to be looking at what are the theoretical and what are also the conceptual framework that we are using in suicide prevention. There are some that are well known right now, and we want to look at where we can go now and what will be the future of those framework and what we should be looking at. So as for starter, what do you think about what are the conceptual and the theoretical framework that are more used in suicide prevention right now?
Sure. So the main one that's being utilized right now is really around a stress diathesis model that Dr. John Mann put forward, as well as the Thomas Joyner has really articulated the interpersonal theory around suicide prevention. And so there are historical ones that are Durkheim's model as well that are utilized, but really the stress diathesis model is one of the key components, where the genetic risk of the person's impulsivity, aggression, interacting with someone's stressful life events, either near the suicide attempt or also remotely, childhood trauma, interpersonal trauma.
And as for yourself, Sharon, you were talking about the fact that you were studying like historical research on suicide. So do you know other framework that were used historically to describe suicide prevention?
Yeah. So here in Australia, we're doing a large national project, an ARC-funded project, Australian Research Council. It's being led by Professor Ben Wadham, and the group is a research unit for veteran suicide and veteran military transition called Open Door. What we're doing is we are doing a multidisciplinary look at veteran suicide from 1914 through to the present, because we've just had a significant National Royal Commission on veteran suicide. So, like everywhere else in the world, I would imagine, we're doing it because the rates of suicide among the veteran, military and first responder community hasn't really budged very much. In fact, some people might say that the situation is worsening for some, particularly the focus on transition for veterans. So clearly the existing decades of what's been done don't seem to be working. So it suggests that existing expertise and ways of doing things needs to actually be considered. And so we're looking back over time to see, for example, I've been doing a policy analysis from 1975 to the present, and my colleague who's an historian has been looking at the archival records of the War Memorial from 1914 through to see how veterans have been describing and talking about suicide in their letters, for example. And I've been looking at the policy rhetoric across that time. So what's very apparent is that there are a few areas in particular where the veteran is very much under the clinical gaze, for want of a better word, very individual approach to responding to suicidal distress, etc. And Jitendra has outlined some of those frameworks that have brought us to that point. So it's very much in the biopsychosocial model. It's very much been the biopsycho and not a lot of the social. So this is where families in particular come in, because they are sitting outside very much of a lot of the current expertise, where the veteran is sent into a system where others' expertise is seen as the complete solution, potentially through therapies and treatments. And it doesn't seem to be working on its own. So we're having another look at it. Sorry for the long answer.
No, that's okay. It sounds like you're highlighting some of the limitations of some of the current theoretical frameworks. And I'm wondering if you, Sharon, or Jitendra, have any comment on some of the assumptions that the current frameworks make about risk, causality, and intervention, and what we might be missing.
Yeah, so I mean, I think it's really, really important to think about not only the family system, but the community. And so some of our work with Dr. Lawrence Kermeyer and understanding Indigenous suicide prevention really looks at not only at the individual and the family, but the community that the person is living in. And I think that framework needs to be looked at in military and veterans, right? So what triggers suicidal behavior? Right now, the dominant theories are really focused on the individual. What's happening with the individual? Does this person have a mental disorder or substance use disorder? We're less inclined to understand and what are the family-based interventions that could prevent? What's happening in the community of the person that they're living with, their peers and their friends and their units in the military. And most importantly, as Sharon is saying, is that transition from leaving the military into the veterans is the highest risk period, because that's really a loss of that identity. And so I think some of the models that Dr. Kermeyer has really worked on to understand the person in the community needs to be looked at much more in our military veterans as we think about research, but also more importantly around interventions.
Yeah, so a more ecological approach that takes the whole picture into consideration. Definitely. Sharon, did you have anything to add to that?
Yeah, I'd add that it also makes assumptions about the flow of information So in an ecological model, of course, the flow of information is very much reciprocal and integrated. So currently, across mental health and also veteran services in general, what families tend to experience is a one-way flow of information. So they're very much assumed to be useful to the assessment, to the system, but then the information they provide is selective information. So it's one way, and they're sourced for their information and how it serves that clinical assessment process, rather than their expertise in the social environment in which the person lives their life. So that's one other point I'd probably add to that. Yeah.
All right, thank you.
And Johnny, do these same frameworks show up also in community-based research or applied research context? Do you know about if those same frameworks apply in your setting?
I believe they absolutely do, Christine. I really appreciate the comments that Jitendra and Sharon are making around like multiple forms of knowledge or multiple forms of evidence in how we make meaning with this phenomenon of suicide. And many of the models that Jitendra spoke to, and also how Sharon has weaved it in, absolutely show up in community-based mental health contexts. They show up in my organization. We've been involved with developing risk reduction frameworks or encouraging care systems to embrace stronger approaches to screening. But as listeners likely know, there is, I think, a growing body of scholarship I've been involved with over the past number of years with leading thinkers like Dr. Amy Chandler in Scotland, Dr. Jennifer White here in Victoria, Dr. Ian Marsh in the UK, who've really tried to bring a doubled approach so we can hold the models, the joiner model that Jitendra spoke about earlier, alongside models that are based upon other forms of knowledge and information. Like, we've very much engaged with people who have lived experience of crisis care within hospital systems, and they weigh in with tremendous insight and value that can sometimes contest or run up against these very dominant frameworks of risk and individualization or pathology. And so I do think it's really important to make sure we hold space for multiple forms of knowing and doing around suicide, because in some ways we avoid the risk of blind spots about what make lives livable, what make lives worth living. And that broader view, I think, that we can definitely leverage in community creates additional opportunities for prevention and intervention, but also shifting the determinants, the conditions in communities that can cause tremendous distress at individual, family, community, and social levels when it comes to engaging with life.
I think that's great. And you not only highlight what some of the limitations are that have been touched on, but how we can better leverage the other types of information that are out there. And that makes me wonder, are there the current models that don't necessarily take the ecological aspects into consideration, do they tend to exclude or marginalize certain types of experiences that are important to consider in the suicide context?
I think just to respond to that, I do think that the adult clinicians, whether they're psychiatrists or providers, really kind of think about the individual. Does this person have a mental health issue? Do they not? And I think really encouraging more of a collaborative framework to engage the support person that might be important. I don't think that we're doing enough of that, not only in military veteran samples, but in the general population. We really think about individual risk in adults, where when we think about youth or elderly, we think about the family and the ecology. So we really need to learn from our child and seniors' mental health and really think about that the person is presenting, as one of my family therapist supervisors said, what's the system that's breaking down? Why is this person showing up with these particular symptoms at this moment? And it's the mental health condition might be one component, depression or alcohol, but it's really what's driving this in a system lens, and really thinking about assessment in a collaborative manner. And then as far as interventions, I mean, I think we're really seeing a lot of interest in cognitive behavior therapy for self-harm behavior, really showing that that has a lot of evidence at the individual level. But from a research lens, we have absolutely limited knowledge of family systems. What kind of family systems intervention is needed when a person shows up with self-harm? And how should we evaluate that and test that in a military or family level? And then really beyond that is really understanding leadership and the community that the person works in is a more complicated component.
Can I add to that? You know, certainly it's so pervasive, the system in which, and it needs, you know, there needs to be a focus on risk, but not at the exclusion of other options. So, and the sense of the person being the sick individual who needs treatment. So other forms of expertise are lived experience expertise, peer expertise. Veterans, like any other group, naturally will find like-minded people. How much that expertise is privileged in the process, in the same way that families find other families, and they find answers beyond the system because the system is not enough. Interestingly, in this policy analysis, the culture of the military organisation has really only come into the rhetoric of the policy rhetoric here, and I'm sure elsewhere, in more recent times. What I found through the 80s, 70s, 80s, 90s was that it was very much not even mentioning the role of the organisation, which was quite interesting, and certainly not before then. So lived experience and peer input would be what I'd add to Jitender's comments.
One thing, Susan, I'll just be brief, and Sharon triggered this piece for me. You know, often the very person, like the very person who is experiencing thoughts of suicide, contemplating taking their life, and I think Sharon has hinted at this in some ways as well as Jitender, is they're often positioned in a very particular way within the healthcare system. And so there's often an ascription of risk, and other things start to inform the nexus around that human liability, decision-making, containment, detention, pressures around beds and availability. So there's a lot of things that shape those interactions. And we've heard directly often from care providers that they do feel quite boxed in their approach, and also the knowledges and the experiences that person is seen totally as a risk, right? There aren't often opportunities to engage in the other dimensions of who they are as human beings. And I am generalizing here, I know, but having operated in those environments myself as a clinician, things can feel quite perilous and fraught, and often the time isn't available there to deeply engage with the deep depth of the person who's sitting in front of you, being subjected to a risk assessment, etc. So I also think that's a perspective to keep an eye on, is what gets lost in environments where risk management, you know, it's very important. We want people to be safe, but at what cost does that dominance have when there's often a need to be relational and build connection? And how does one do that in a busy emergency room? And I know lots of very caring professionals do their best, but also I know that those resources can be very, very limited in supporting someone in a suicidal crisis. So I just wanted to add that dimension about the value and the importance of the knowledges and information and breadth and depth of the human being who themselves, you know, has been deemed to be in suicidal crisis.
That's a great point. Johnny, it makes me wonder how some of these limitations or blind spots that we have impact our efforts in the areas of both prevention and intervention. And it highlights, the theme that brings us here today is our families, another one of those factors that don't necessarily fit nicely into some of the models and structural systems in which we're trying to work these days.
Well, I'll be brief with a quick answer to that. I think it shuts off sites of possibility, right? And so I think in those environments, it might, and Sharon said this so clearly, it might obscure the opportunity to involve family. And I think all of us on this call agree that that can be, when appropriate, really, really important. Or, the framing might be simply around the questions. Are you suicidal? Do you have the means? Are you planning intentionality right now? Are you alone? Rather than broader conversations about the person's experiences. And Jitendra said this so clearly earlier around the person potentially experiencing racism or bullying and harassment or violence. We know those are very, very strong risk factors. And so sometimes I think those lines of gentle inquiry are hidden from view when there's a very dominant framework in place, right? And other sites of possibility are obscured. One story stands out for me where a young person arrived in the emergency room in community, and they were at a lived experience gathering we did on suicide prevention. And often the standard procedure is to remove everything from the person when they arrive in a hospital so that they're safe. But they didn't have access to a clock or a watch. They didn't have access to points of comfort. And what they said, one of the most important things they hoped to hear was, thank you for coming here. Thank you for trusting us. We care about you. And what they experienced was actually a kind of a launch into being contained and also assessed. And so I think what those dominant frameworks can sometimes, get in the way or obstruct good relationship building when it comes to supporting people in crisis, whether you're a veteran, a young person, a family member, or whomever.
So they sometimes miss the basics of just acknowledging, we know it was difficult to take this step, and thank you for coming in. We'll take the next step together. That's important.
Just adding to Johnny, I know no one's mentioned that word moral injury yet in the context of veteran suicide. And in Australia, we've certainly, through the recent Royal Commission, the sense of moral injury and its contribution to suicide, the context in which people are serving and in which they're transitioning and after transition from the military. And equally that families have a sense of moral distress because they're sitting outside on the other side of a mirror which they can't penetrate, even though they can see the problem very, very clearly often, and the solution. But they're knocking on the door of a system that's not listening to them. So that sense of moral injury for the veteran potentially and moral distress, then there's a whole literature on that, which I'm sure Johnny and Jitendra have a sense of. But just the other comment I'd make is around the analysis that I've been doing here on policy. What I've found very useful is a framework by Carol Backey, which is, what's the problem represented to be? And Johnny, your comments about silences. So Backey asks, where are the silences and what's produced by that representation of the problem, etc. So very logical sort of ideas around who's in the tent, who's not in the tent, what are the consequences of that, etc., etc.
Thanks, Sharon. Jitendra, do you want to add something about this perspective?
Sure. Yeah, so I do think that a couple of points, just as Johnny and Sharon are saying, that one of the challenges that patients and families often face is that if they open up and talk about their risk of their thoughts about suicide, is, as Johnny is saying, are they now going to have a clinician that gets anxious And now the person is now going down the path of hospitalization, taking their rights away to protect. So one of the areas that is quite, is not just in military veterans, but in generally around suicide prevention, hospitalization is kind of the standard. But there's actually no evidence that hospitalization actually reduces suicide attempts in the future. So we have this intervention that we utilize because it makes the clinicians feel safer, as Johnny's saying, but we're taking people's rights away. But we don't have alternate models. We don't have crisis teams that will follow up daily to make sure that the person is staying, and family-based intervention. So we're trialing some of those here in Manitoba, virtual wards, right? There have been in the UK hospital home teams. Unless the person is psychotically depressed and they need hospitalization, if somebody is in a crisis, often they come into the hospital, they're not getting any mental health treatment in the hospital. They're getting some supports, but they're not getting evidence-based psychological treatments. They're not getting family-based interventions. So I do think that we need to really intentionally look at this, not only for military veteran suicide, but all hospitalizations and suicide. Should there be more day treatment, virtual day treatment, such that you can help the person in their natural environment be able to recover from self-harm behavior or reduce that suicide risk, rather than hospitalization and then they're have lost their rights and that kind of thing. I mean, this is where we're at in the field internationally, because there have not been randomized trials or even pragmatic trials. But what we do know is that hospitalization is associated, when the person leaves, pretty high risk of suicide. But we haven't really worked on models to say, can we do crisis interventions in the community? Because they're challenging trials to do, right? Any ethics board would be quite nervous about these things, but we need to really challenge the status quo on this. I don't know if Johnny or Sharon have thoughts on that.
Well, the response is only so good if the people are in this system. And there are a lot of people, obviously, in the veteran community and elsewhere who have thoughts of suicide and complete suicide, having never contacted the system. So we need alternative approaches in the community for those people who are never actually going to enter or be the system, be aware that they're even there. And that's why peer models and family models are so important. It's that sense of people actually understanding and recognising and that something's going on, that something's not right, as much as it is, yes, we need to get you to hospital, yes, we need to get you to see a doctor, your GP, whatever. There's a lot to do before that point, even because it can be very quiet and present for many people.
But sometimes what's difficult with those community perspective about treatment or something like that with people having suicidal ideation or suicidal attempt is that we put some responsibility on the family, because we ask the family to be the resources to help the person with suicidal need. But do you think that we can have another vision of how the family can be implicate in those suicide prevention? They are not only risk factor, protective factor, or resources. Do you see family having another role in suicide prevention than only those risk, protective, and resources?
Well, I might chime in. I really appreciated Jitenda's candor there around the limitation of models, and we have defaults in our system, right? And I'll get to your question, Christine, on the family piece, but I think it's really important to acknowledge that here in British Columbia, Hospitals are often the default for someone meeting that risk, and often the transporting agent are the police, right? So if you kind of look at that critically, you can understand it at some levels, but it's also quite a strange setup where someone experiencing a health crisis, a health emergency, i.e., a suicidal crisis, are conveyed to hospitals by the police, and I do get the risk of violence and the risk of harm around firearms, etc. But also, I think police carry a lot of folks to hospital who don't meet those risk pieces. So I think calling that into question is so key. And I think Manitoba and other jurisdictions across the world, Dr. Jamie Livingston's been researching this. We've been actively deploying teams that carry so many of the characteristics that Sharon's described. So co-response in the sense of a lived experience perspective, crisis responder, people who are understanding the system. And our teams in British Columbia, they're called circle teams, have responded to close to 15,000 calls. And they've avoided the need for conveyance to the hospital and the need for police to come along the majority of the time. And it's very interesting from a practice basis to kind of understand this practice of community-based suicide intervention. And it kind of meets a lot of the characteristics that have come out on this call. These teams have time. They spend time with folks in community. They do follow-up 2 days later. They do a little bit of following in and around community. And we've heard from people who've used the service that because they know there's a predictability, there's an inherent dignity and a respect in the care, they'll call this team to avoid the crisis worsening and them needing more intensive interventions like a trip to the hospital. And so that may be coupled with community-based crisis care stabilization. There's some really beautiful examples in Australia, the UK, where crisis care, suicide care is delivered outside the context of an ER in ways that are very driven to populations, so First Nations folks, veterans, families. I think there are some very neat possibilities on the horizon that can hopefully attract the level of research that dominant models of suicide prevention and intervention attract. And I think to your point, with those community-based possibilities, Christine, there's ways to bring families alongside. I think of narrative therapy as a therapeutic intervention where family members are often enlisted when it's appropriate, not just as a risk or a protective factor, but as part of the care team alongside the person in shoring up reasons for living. And there's opportunities for good evidence-based family systems work and those kinds of pieces. Because it's amazing. I think it's amazing when you think about suicide, it's about possibilities being shut down. It's about being in a black and white tunnel vision place. And unfortunately, the system, I think, starts to shut down possibilities too. You can't do this. You can do this. You can't be safe. And to me, that's a kind of a tragic irony in what I think this conversation is exposing in some ways about how do we create more possibilities for living, which includes, I think, seeing family members as a real site for bringing them alongside the therapeutic work of supporting someone to stay alive.
I'd add, Johnny, it's around the connections, isn't it?
Absolutely.
So those possibilities are actually the loss of a sense of those connections, that the person is sitting in a family, but they're in isolation from their family and community, in their sense of what they see as options.
Right, Sharon, and as Jacinda said so eloquently, like often the default is, well, let's suspend all connections around this person by placing them in involuntary care or seclusion or restraint. And I know that doesn't happen all the time, and it happens often for very good reasons because we have a duty to create safety and the state intervenes. I get it, but sometimes I think we might go too far and those connections that you cite completely get suspended, which I think can lead to further isolation, despair, and disconnection. All of the things in Joyner's model start to tick up, right, when we detain
and the
folks
agency, agency of the person. Yeah.
Absolutely.
Yeah, as we discuss some of those possibilities, I'm wondering if there are any unique factors in the public safety, military, and veteran communities that would need to be considered when looking at these different types of treatments and interventions.
I would really add not only for this specific factors, but the idea that the shift in the last 20 years in the model around suicide prevention has been from treating the underlying depression or substance use to seeing self-harm behavior as equally important to directly target. So the way that I explain it to patients is self-harm behavior is similar to if you're treating somebody with diabetes, high blood pressure, and kidney disease. Each of those three problems need to be really looked at in a systematic manner. And as Johnny and Sharon are saying, really, the evidence is really around what we call the narrative assessment. So really trying to understand, why did this person think about suicide or attempt suicide in a really their own words? And so let's not put our models of, well, we think this is important, but really understanding that narrative assessment and then trying to, if interpersonal family issues are coming up, well, that's an important intervention. If racism or financial stress is coming up, well, we need to look at that. But I think that that's been a major change in suicide prevention in the last 10, 15 years, is thinking about self-harm not as, well, if we treat the underlying depression, the self-harm risk will go down. That's really shifted. And I think for our military veterans, and it's really means restriction is really, really important, right? I mean, we know the most powerful interventions are limiting access to whether it's firearms or medications, and then that, as Sharon mentioned earlier, that transition phase seems to be a huge risk, and really helping the service member navigate that change in identity is such a major factor that I think we could do better around that, and how to have evidence and around that phase change is very, very important.
I think I'd add, Jitendra, thank you. Your comments are well met. The other thing that I know that many militaries focus on increasingly is because these are unique jobs, whether they're public safety or military, and so right from the when people are joining the military and exiting, the sense that the person and families need information and awareness about the role and what to expect potentially. And we become military families, we become police families or fire families because it's our identity as much as it is the person who's serving. But a lot of families say, well, I wish I had have known that at the beginning. So it's important, the awareness raising and education for families as well, I'd add to that mix.
Definitely giving them some idea of what that culture is like and what they can anticipate in terms of the experience, as they embark on that in the beginning. But as we talk about some of the ideas that you've all mentioned, I wanted to ask Sharon what you think it might take to further legitimize some of these approaches within mainstream suicide research.
I think we need to include veterans more. We need to hear more from veterans about what they say has been helpful to them. Sadly, we don't get the chance for veterans who have suicided, but we certainly can speak with veterans who've been in that situation of feeling suicidal. So more research that complements the existing research from the voice of veterans and their families, I think, about that gives some agency in this to actually add the expertise and evidence that they bring from their lived experience. Well, I think there's some solutions in there if we only listen to,
And I was wondering, because Johnny was talking previously about the fact that mainly when there's a suicidal crisis, people will call the 911 or the police, and the police will go. Have you heard or read or seen research about what are the needs of the family? Because as a family member, if I need to call 911, like I must be like in crisis myself about doing so. And usually when we're looking at research on families around suicide, I've not seen a lot about how the families living this kind of crisis and what are their needs. Have you seen that, or have you had any input or ideas in your work field about those needs of the family?
It's a great question, Christine, and I think your example draws into relief what is a reality for many family members who are needing to make that decision to call 911. And you know, and I think I've sat with a number of parents, particularly parents over the years, of a range of humans who've described as how difficult that is. I think there's a real space for, as Sharon has said, you know, really engaging with those knowledges. And I think it's actually, you know, I don't think it's never been done, but it's a fairly perhaps recent initiative to involve people with direct experience of suicidality and crisis to provide expertise and insight into systems reform or care reform. I think sitting with bereaved families, and often bereaved families face tremendous stigma in systems as well and are often not engaged with, or families who've been in those spaces, they have, as Sharon said a moment ago, often solutions and ideas, you know, around how to manage those very difficult situations. Because there really is a cascade, right? If I were to walk onto the street right now, declare I'm suicidal, there'd be a very predictable cascade of events around me. The police would come, I'd be conveyed. If my sister or my parent called, there's a similar cascade. There isn't room to intervene with that train once it's left the station. And so I do think you know, I see family members really weighing in on advice as to how to support people living with neurodivergence, like disorders called autism, right? And how police can respond better in that. And families have been a significant informer around better practice there. So I do think asking the question, finding safer spaces to engage families with lived and direct experience of supporting a loved one in suicidal crisis, are often very real spaces, so that we can avoid families feeling kicked off the care team or kind of left out of the equation, or actually left behind once that cascade of actions starts to take flight when someone's at risk and apprehended and taken.
I mean, I think one of the things also to think about are some of the psychosocial interventions being couples and family-based and developing actual. Like we've done this with post-traumatic stress disorder, for example, where we understand that PTSD does not only affect the individual, but it impacts a family. So there have been therapy models that have been developed. Well, should we also consider that for somebody who's had self-harm in the family, and consider creating a psychological family-based intervention? Because, you know, that family member is impacted by self-harm, but right now the standard of care is there is nothing really provided unless the person asks for it. But I do think that important component of the family unit in the system is so important, and really understanding as to what are the drivers of self-harm in this person, and what are the interventions, and really trying to match them. Because the good thing about suicidal behavior, it is less common than depression and alcohol. But the problem with that from a research lens is you really need large, expensive trials to actually show that something works. And I think we have to now pivot and invest in those kind of interventions, because as we're discussing today, the standard of care is based on not a lot of evidence what we do, because nobody's actually invested in a proper trial on these things. I mean, over time, cognitive behavior therapy for self-harm behavior really has now multiple randomized trials showing that that should be an intervention. That's at the individual level. But what's needed at the family level? What's needed at the community level? Those are important. But I would really look at that family level one as a very important target.
Can I just add, Jitendra, something that gets in, it seems to come up all the time and gets in the way, and it's very complex, is the issue of confidentiality. And Johnny, your comment about families being kicked off the care team reminded me, it often is the barrier. And not all families want to be involved to that level, but and the person may not want their families involved in their contact with services or whatever. But the issue, I think there's a lot that we need to understand more about where we position confidentiality, so that the person lives in a social context and yet they're separate from that context, and confidentiality is often the framework that is put up, and it's important for the person to have confidentiality in what they're sharing with who they're deciding. But for families often bear the consequence because they're living with the person 24 hours a day. So if I have someone who tells me, well, I can't tell you anything because of confidentiality, and yet I'm living with the person 24 hours a day and I'm bearing the consequence of that, there's some issue of vicarious trauma to me as a family member. So I don't think we do that conversation as well as what we could around confidentiality, and research into how systems and services and how we all navigate confidentiality, just as a thought.
Yeah, I mean, I think that we had a critical incident in Manitoba with a civilian where that really was challenged, because, as Sharon, you were saying, the clinicians get stuck in this idea of privacy. But when self-harm and safety is there, it's really important to have collaborative decision-making. You still have to respect the person's privacy, but I think if you're going to break that confidentiality, we actually have to create Manitoba-based guidelines to say, you get a second opinion from another clinician, you get a collaboration, you let the person know that, unfortunately, because of these reasons, I have to break the confidentiality. But as you're saying, Sharon, I think that we really could do a lot more around both research and practice around how do we engage families in suicide risk assessment in a collaborative manner, still ensuring that there's privacy, but as a clinician seeing the person for the first time, if they're saying, don't talk to this person, I get more and more nervous through the interview. So
yeah, and working with the veteran too around that. Yeah.
And so based on everything that we've talked about so far, what would each of you say is sort of one first step that we could take in the direction of broadening the lens and, making some progress in the direction of advancing suicide research and also prevention and intervention efforts based on some of the factors that you've highlighted today?
I mean, from my perspective, I think one is to try to really increase access to CBT for self-harm behavior. So doing that in a systematic manner. I was at an international suicide conference where, in the US, if somebody has a military veteran has self-harmed, the clinicians have options of CBT for suicidal behavior, problem-solving therapy, or dialectical behavior therapy. So really, I think one of the challenges often is that we spend a lot of time building new evidence, but we don't scale evidence in a systematic manner. And we should be really learning from our partners in other organizations and saying, let's scale things rather than, another pilot project that gets stuck. And then the second is really that area of how do we engage family members both in assessment and treatment when somebody's presenting is, I think, we can learn from how we've worked on improving engagement with families in PTSD treatment and depression treatment, but how do we actually develop the evidence and do pilot randomized trials that would actually help to keep people in the community and as Johnny was describing, like, moving that default of admission, like those are all novel things that we would have to really spend a lot of energy to move and change the flow, because I think the clinicians really worry, of course, about the high risk. So we have to provide alternate interventions that are better, not worse, than hospitalization. And that's daily treatment, crisis team. Now with post-COVID, we can do things. Virtual care is really advanced post-COVID. So you can do a lot of things at home that previously was very challenging to do.
Okay, thanks, Jitender.
Yeah, and I think Jitender makes such an important point, right? I think, well, I know there is significant evidence behind a set number of interventions, and I think there's a growing base of awareness that we can rely upon wise practices and knowledges and practices that have been present within Indigenous communities as well for time immemorial around how to support community members within First Nations and Métis communities too. And so, but I think that the crux of what Jitender was saying is that so often those things are not available, right? They haven't been scaled, as Jitender said. They're too expensive. Publicly funded psychotherapy isn't a reality in many jurisdictions across this country, at least in Canada. Maybe it's different in Australia. And so these defaults are also driven by access issues, funding issues, other pieces that really do warrant attention too around, thinking through, how do we move beyond containment towards and detention towards more care and treatment. And that's why I think no matter the opinion one might have on the zero suicide ambition in the United States, there's such a strong emphasis within that model of making available things that can work, including family systems or family-based interventions as well. And so I often think it can be either a failure of funding or a failure of access, or at times a failure of imagination, when it comes to bringing all the things that we would bring to any other life-threatening condition, bringing that to bear around someone in crisis. There's no question, in other forms of life-threatening crisis. But when it comes to suicide, often, we hear a lot from families where it's a very, very brief visit. And there isn't that care and attention to the aftercare that's required during that incredibly high-risk zone after someone's been released from any kind of facility, a hospital or longer-term inpatient care. So I really appreciate what Jitender's saying, because there is limited evidence in some spaces, but there's also strong evidence for particular forms of intervention and practices that can make a real difference.
No, absolutely. And as you're all providing your feedback, I'm kind of picking up on three specific themes: care, connection, but also the continuity, that it's not just a very short-term intervention, that there has to be a continuity of support. and care within, that individual's connections with their environment and their family. So I just want to wrap up today's episode. I want to thank our guests for their insights and Christine for co-moderating. I also want to thank our listeners. But it's been an interesting opportunity to listen to insights on the state of suicide research. And we look forward to continuing the dialogue on how we research suicide in episode 3. So thank you to everybody for participating today, and we'll see you in episode 3.
Thank you.
Thank you.
Thank you.
Thank you.